we have looked at AI from many various angles, but today we're very fortunate to be looking at the issue of skill, and there'll be very exciting panelists who will introduce themselves directly. And as you know, we do this on behalf of ANADAC and P2P. Dr. Mehari, over to you for your remarks.
Uh, Good morning, good afternoon, and good evening to everyone. Sorry, I'm on the road, so that's why I didn't put on the video. But thank you for joining us from around the world. On behalf of People to People and ANADAC, it's my great pleasure to welcome you to today's webinar, Artificial Intelligence at Scale, Experience and Lessons from the Healthcare Space. Artificial intelligence is no longer a future possibility. It is becoming an integral part of healthcare, transforming clinical care, education, research, and health system. Yet, technology alone is not enough. Successfully deploying AI at scale requires strong leadership, high quality data, robust infrastructure, sound governance, and above all, investment in people. Today, we are privileged to be joined by an outstanding panel of internationally recognized experts whose work spans clinical AI, virtual care, digital health infrastructure, and workforce transformation. Together, they will share practical experience, lessons learned, and insights that can help guide healthcare leaders, educators, policymakers, and innovators, particularly across Africa. As we navigate this rapidly evolving landscape, our hope is that today's discussion will not only inspire new ideas, but also foster collaboration to ensure AI improve healthcare delivery in an ethical, equitable, and sustainable way. Thank you for joining us. It is now my pleasure to hand over to our moderator who will introduce our distinguished panelists and begin today's discussion. Thank you so much.
Thank you so much, and good morning to the wonderful panelists and our guests. And thank you very much, P2P and ANADAC. I'll start without much ado because we don't have that much time. So artificial intelligence is arriving in healthcare faster than almost any technology before it. And nowhere are the stakes or the opportunity higher than across Africa's health systems. The question is no longer whether AI belongs in our hospitals and clinics, it's whether we can deploy it at scale in a way that delivers real lasting value without widening the gaps it promises to close. To explore that, I'm joined by four incredible leaders who've done this work at the bedside and at the frontier of technology across national health systems and at the scale of millions of patients. I'd like to first introduce Dr. Isabel Pimenta, who's a hospitalist and radiologist at Johns Hopkins, where she leads quality improvement and researches AI in medical imaging. She's also spent over a decade as a health economist at the World Bank. So she sees both the bedside and the balance sheet. Next is Dr. Milton Chen, co-founder and CEO of VC, the telehealth platform NASA astronauts use aboard the space station. A Stanford PhD, he's delivered care everywhere from refugee camps to homeless shelters, a pioneer of medicine in today's world's hardest settings. Next is Dr. Desalegn Melesi. He's a global health data architect who's built systems reaching 25 million people across Ethiopia, integrating data from 6,500 facilities. He's a core technical lead for Countdown to 2030 across more than 30 African countries. And finally, Dr. Ronke Akirile, a National Director of Staff Experience and Engagement at NHS England, leading the ambition to make it the best place to work. With a doctorate in organizational change, she's our expert on bringing people through transformation. Without much ado, my first question goes to Dr. Isabel Pimenta. Medical AI isn't new to Africa, In fact, it's been piloted as far back as the mid-1980s in Kenya, Egypt, the Gambia, and several other countries. What's changed is the power of today's tools, from imaging to precision medicine, that can tailor therapy to a patient's genetics. But the first question experts insist on is always the same. What health system problem are we actually solving? Isabel, you're both a clinician using AI in imaging and also a health economist. Where are you seeing AI deliver genuine clinical value today, and how should leaders weigh that against cost effectiveness and opportunity cost in resource constrained settings?
Well, thank you. First of all, hello to everyone, and it's a real honor to be part of this panel and be able to be among so many distinguished speakers and leaders. I'm speaking from a big academic center in the United States perspective, and I'll try to bring some examples of how we're deploying AI, but I'll try to kind of just also draw a little bit of a contrast to less resource areas and centers. I'm myself from Brazil. I'm very used to not as well-resourced center as the one I'm speaking from. And at the same time, even the US is well known to have what we call desert access areas for healthcare. So in which what I'm describing here does not necessarily apply. So I like to start there. And I also would like to kind of say that I try to also speak not only from the clinician perspective, but from the economics and perspective after having worked for 10 years as the World Banks. But let me kind of go back to some kind of use cases and and hopefully that kind of provide a little bit of practical examples of how AI is being deployed. The way I try to think, as always, starting with the problem. There are a lot of kind of hype in the artificial intelligence technological revolution for good reasons, but also I think it's very easy to get carried away by some of the features and powerful capabilities of some of those tools. And at Hopkins, we always try to go back to some of the basics. What is the problem we're trying to resolve or address with AI? And how and what is, and from there, either develop in-house or go after external enterprise vendors or that could offer available tools that could potentially meet our needs. But I would like to kind of talk about some use cases that I think could be particularly relevant to this discussion. I like very much the example of retinopathy, which you might know. Diabetes mellitus is a big chronic disease that affects vast numbers of people, and one of its main kind of damages that it causes to the body is problems with the retina in the eyes and eventually poor vision and blindness. So the first autonomous AI diagnostic FDA ever cleared was back in 2018, and it addresses exactly that problem. It detects diabetic retinopathy at specialty level care accuracy. What we use in medicine to kind of be able to measure some of those performances, 87% sensitivity, 90% of specificity, inside a primary care visit with no ophthalmologist required to interpret it. Another good example is stroke. In rural US hospitals, we're running telestroke plus AI networks that cut door to needle time from 112 minutes to 81 minutes. That kind of saved brain cells in a stroke situation. Because AI can read a CAT scan and support transfer decision directly to even before a neurologist is on the line. Or, for example, the Mayo Clinic published back in 2019 AI algorithms in which standard EKGs can pick up silent and asymptomatic heart dysfunctions years before symptoms are present, and with accuracy that compares favorably to mammography for breast cancers. None of those. Go ahead,
Dr.
sorry.
Thank you, Dr. Isabel. If you wouldn't mind, hold that thought. That's a perfect place to pivot to Dr. Chen. Roughly 1 billion people get care at facilities with little or no reliable electricity, and internet use averages about 23% in low-income countries versus 94% in high-income ones. Yet high mobile penetration is creating a foundation to leapfrog. And physical advances like solar power and satellite internet are reaching the last mile. The technology that matters here is the technology that works when the power flickers. And to what you're saying, Dr. Isabel, with these advances in AI, and we have these issues with power and energy, I wonder, Milton, who is taking care of the space station and rural areas, you've delivered telehealth from the space station to refugee camps. For systems with intermittent power and connectivity, what does responsible virtual care and remote monitoring look like today, especially in light of what Dr. Isabel was saying? And which emerging trends like edge AI or on-device tools, models, should leaders watch rather than chase?
Thank you so much for that opportunity to share with you. I think the starting point is electronic medical record system. So I view that as a foundation. In fact, if you look across Africa, most of the places outside the big cities, they are still on paper medical record. But the problem when you're on the paper medical record, you cannot leapfrog into AI telehealth. Again, so one of the common complaints people say, well, I don't have reliable internet, I don't have reliable power, I'm stuck on paper. The good news is that no longer true. There's a whole generation of EMR today that can operate online and offline. So again, there's really no reason not to deploy EMR. You can make it super simple in there. The beauty of that, as soon as you have EMR, even in basic, you get just a beautiful set of capability, for example, from what statistics to improve, right? What are the key metrics in the healthcare system? You could dive into like real-time supply chain medication inventory. Like the rule of thumb, right? About 20 to 30% of the medication are wasted because you cannot manage that, right? Just a really simple thing, right? That's the first point. Then the next thing I think was really exciting is instead of thinking about large language model, think about small language models, specifically about edge. Again, I know I'm sure all of you guys have used like the Anthropics, the Googles, the OpenAI, like all these, right? And they're really, really exciting thing. But those often is just not practical when you get to the edge where the internet on and off, electricity. The good news is there's a whole suite of AI models is designed to let you operate on the edge. You don't need to have this sort of big internet and so on. Again, there's many methods you can go to places like Hugging Face and so on, endless number in there. So the way I want to think about there's a set of things you can be that's useful now. The way I want to think about it is that you should definitely use like Google, Anthropic, all these things. But I don't think they're sustainable because if you look at their business model, they're losing money every time you use it. If you were to deploy this in your country, what they go do is they will have a business model that get you hooked, low price. Soon you operate scale, the bill for that would be so expensive. Like you have even like